So for those of you who don't know me, my name is Ioannis. I'm an endocrine surgeon at City Hospital. I'll talk to you a little bit about our clinical outcomes in terms of managing these neck hematomas and a little course that we have set up trying to help with that. So thank you very much for the invitation, much appreciated. I have no conflicts of interest. So we talked about the neck hematoma from my previous colleagues, so we heard about it. So I won't go too much into that, into the details. I'll just say that depending on how much time has passed from the occurrence of the neck hematoma, you can get different presentations. So when you're in recovery, you may or may not have bruising, depending if the neck hematoma is fresh or not. If the neck hematoma is literally happening in front of your eyes, you might not get necessarily the bruising, you might get a swelling. If enough time has passed, then eventually you will get the bruising as well. Clinical signs, we've seen them. The patient starts feeling distressed. They have a sense that they are dying, and it might lead to cardiac arrest. I had a little special interest in these neck hematomas when I was in Houston in MD Anderson. I looked at their neck hematomas over the last 2 decades. And especially my interest was how did the anesthetists manage to reintubate these patients. And we came up with a little algorithm over there on how to reintubate these patients. And surprisingly, actually 60 to 70% of the reintubation for these neck hematoma patients were quite straightforward for the anesthetists. So that was a nice message that came from this paper. And in this US center, their neck hematoma rate was 0.7%. So in terms of our clinical outcomes and where do we stand here in endocrine surgery in Nottingham, we are very close to the national average. So we're not doing too bad ourselves. So our neck hematoma rate is quite rare, it's less than 1%. So we're quite pleased with that. Now, in terms of the period that I've been here, I'll talk about my personal outcomes. Over the last 3 years, 491 operations, close to 100 total thyroidectomies, 216 hemithyroidectomies, and 177 parathyroidectomies. My neck hematoma rate is 0.6%. All these 3 cases, which correspond to 3 cases, all of these 3 cases happened in theater recovery. There were no patients who bled on the ward, and I will present you how we managed these 3 cases. So the first case was a 70-year-old female that had a large thyroid goiter, background was Graves, and she had a total thyroidectomy. She had a neck hematoma in recovery, and again, our recovery nurses at City are so good that they spotted it immediately. We got the patient back to theater straight away, and I know I'll say something that I don't know if you've heard that before, but you can actually manage these cases under local anesthetic. So with a good team around you, with a very, very good anesthetist, that I'm really, really blessed to have good anesthetists working here. You can just put the patient in position. If there is no massive airway compromise, you can just open the wound under local anesthetic. And that's what I did with this case. The patient had a length of stay of total of 2 days, and she had no adverse clinical outcome. Second case, again, was 47-year-old male, total thyroidectomy, large bilateral multinodular goiter. Again, a hematoma in recovery. Again, the same thing. Recovery nurse alerted us, took the patient back to theater, and again, a bit of a washout under local, length of stay 2 days, and no adverse clinical outcome. And the last case was a 65-year-old female that had a goiter and needed a total thyroidectomy. This time around, I tried to do it again under local, but it was a proper arterial bleed that was deep. It wouldn't have been so easy to control. So we actually put the patient to sleep. Again, length of stay 2 days, no adverse long-term effect. So these were the 3 bleeds in around 500 cases over the last 3 years. As I said, I'm a little bit obsessed with this neck hematoma. So this is my op note, what it looks like, and you'll see that it's multiple pages, but it does contain the SCOOP protocol and together with other advice on what to do in neck hematoma if the patient is alert, if the patient has arrested. And to highlight Steve's point and everyone else's previously, you can see it's too small, but in the post-op instruction, it says monitor wound for hematoma formation. In case of wound hematoma, inform doctor on call, anesthetist on call, and call me. Open the wound at bedside. If vital signs deteriorate, do not wait. So from my side, if there is any patient that they have a neck hematoma and the vital signs deteriorate, I strongly encourage anyone to open the neck wound. They will save the patient's life. We'll just go back and stitch the wound, and that will be it. But opening the neck wound is really simple in reality, and it will actually save someone's life. So we shouldn't be afraid of doing it. And as Helen said, it's really important to actually open the strap muscles, not just the superficial layer. Other things that I personally do, except my op note, is try to put some sort of box, neck hematoma box, what is later called as neck hematoma box on the wards. In essence, is nothing, just a plastic box with a knife and scissor and some swabs. It doesn't have to be fancy. All you need is a knife and some swabs to open the wound. I am a little bit obsessed with not covering the wound because I want everyone to be able to see the wound, including porters, including anyone who passes by. I think it's really important for the wound to be visible. If you have a big dressing on top of the wound, then if the patient has a neck hematoma, you will not understand that until the vital signs deteriorate. While if the neck is completely exposed and everyone can see it, you might actually pick it up at an early stage. And you've seen from the cases before, if you pick it up at an early stage and you manage it appropriately, then the patient will have an excellent outcome. And it's very, for those of you who work at City, I go around if they are in recovery, and if the patient has a blanket, as they usually do in recovery, I take it down so that the neck is completely exposed. But again, that's just my practice. So that was the things that I do on my own patient. But this is an unmet need that all staff need to be trained. It can't just be the surgeon that knows what to do. So since 2020, actually, we set up at NUH this neck hematoma and post-op hypocalcemia hands-on training course. And what we do in this neck hematoma course is around 2 to 2.5 hours. It's free for everyone. We train medical students, nurses, surgical care practitioners, doctors of all grades. There's a bit of theoretical bit. So what we do is there is a presentation where we talk about neck hematoma, how to manage it. Then there is a hands-on hematoma model on where the attendees get to practice how to open the wound hematoma. And then we do a little bit of scenarios, role playing. What would you do in this case? What would we do in that case? And then they have their MCQ and their feedback. In essence, what we do in the course, we teach our participants that there are 3 scenarios. The first scenario is the patient has a neck hematoma, but they're stable and the vital signs are alert, and you have the time to manage things. Take the patient to theater, intubate if needed, and evacuate the wound hematoma. The second scenario is the scenario in which the patient actually is deteriorating in front of you and it's about to arrest, and you actually need to open the wound on the spot. And I believe this is the first case that John presented. The patient was in recovery and they were just deteriorating in front of the staff. So this is the scenario in which we actually teach everyone: do not hesitate, open the wound. You will actually save the patient. And the third scenario, which what we teach, is that if the patient is already arrested and they have a neck hematoma, forget about the neck hematoma. Just get the patient's heart back And then once there are extra pair of hands, or if the normal heart function has resumed, then you can evacuate the hematoma. So far, as I said, more than 15 courses, we've had very, very, very good feedback, and people were really found it very, very helpful. What I tell the participants is at the beginning of the course, look, this course is going to be very depressing. I'm going to depress you. I'm going to talk about things that are not nice, things that are very, very rare. But it's best if I actually depress you today, but you know what to do, rather than finding yourself in such a scenario in the middle of the night. Because all the times that I found myself in such a scenario, it was absolute, and I'm talking about big university hospitals in the UK, it was absolute chaos. And before coming to NUH, of course, it was chaos. People did not know what to do. It's a very, very stressful moment. And I certainly hear the comment about the patients having needing some psychological support after such an event. It's really traumatic for both the staff and the patient when something like that happens. So this is what we're doing at NUH, and what was happening nationally was that the British Association, as we heard, came up with a scoop guideline, and they encouraged the patients to encourage the early opening of the wound. And that came, as we heard from Helen, from the Oxford case. And I'll say that the kudos really go to Greg Sadler, the president of the British Association of Endocrine Surgeons, that made it a bit of his mission to get to bring this to the surface and educate colleagues, and to the team now that is in Oxford that took on that mission. It was really nice that after we set up the course, we heard the guidelines that came up that highlighted that everyone needs to be trained, and this is certainly what we have been doing. As I said, we train everyone from medical doctors to nurses to surgical care practitioners. Anyone who is near such patients in reality should know the basics of what to do. As you all know, trying to set up anything doesn't come easy, but this case just made it really worthwhile. Just in the last year that the course has been running, we had one of our FY1 doctors that attended the course, then went on in a district general hospital in the region, and sent me this message. Basically, they found themselves in A&E with a patient that had a neck hematoma, and pretty much they were the only ones who knew what to do and open the wound, and the patient managed to survive. So it's I think that I strongly feel that we should really try our best to educate everyone who is looking after these patients. They will really make a difference, and they will actually save someone's life, as it happened in this case. Last but not least, I would like to say a big thank you to all the team that looks after the patient, our anesthetists, the theatre teams, recovery staff, ward staff, ITU staff, because with their excellent help, then we can have very, very, very good outcomes. Provided we talk about it and we train ourselves, we can keep our patients safe. So thank you very much.